With with that said, uh, let's get started. So I thought tonight we would start by just talking a little bit about what valley fever is. Most people are accustomed to the idea of a viral infection, say a cold, for example, or perhaps even a bacterial infection like a urinary tract infection. Well, valley fever is actually a fungal infection. So it's caused by a fungus that lives here in the Southwest, or I should say, it lives in the Southwest, but you now find it widespread throughout California, parts of New Mexico, Texas, and a number of other states. And certainly this is one of the things that people feel is happening because of climate change. As the climate changes, the distribution of valley fever is widening. So we're beginning to see it in places that we didn't used to see it, including, believe it or not, even in marine mammals, which at least is a surprise to me, since it's something that lives in sandy soils that aren't typically found as close to large bodies of water like the ocean. But as a fungal infection, the way that it's most commonly acquired is through inhaling the spores. So the fungus lives in the soil. It doesn't produce mushrooms, but it does produce spores which get into the atmosphere, get into the air. Certainly here in Arizona, when we have the monsoons, when it gets windy, it stirs up a lot of dust. And believe it or not, all of us, people and pets alike, are breathing in the spores, whether we realize it or not. In fact, even people who live in homes with, say, air purifiers are still going to have to deal with a potential spore burden. And certainly for many of us who've lived in Arizona for a while, or perhaps even grew up in Arizona, at some point you were probably exposed to it. And certainly the majority of people, and I would say that a significant percentage of dogs, inhale the spores, might even get a brief illness due to inhaling the spores, but their immune systems are capable of fighting it off, and you really never knew that you had valley fever. One of the unique things that, and this will come up again in discussion, in the discussion a little bit later, is that valley fever I would describe as a very enigmatic condition. When we're talking about certain types of viral bacterial infections, I think at times we're used to a predictable pattern, but because valley fever is usually acquired by inhaling the spores, rather through what's called like direct inoculation, where you get, say, poked by a stick, for example, and spores enter the body that way. Once the spores gain access to the bloodstream through the lungs, they can, in theory, travel to any part of the body. And I use the term enigmatic simply because depending on where those spores choose to set up shop, the clinical signs could vary quite a bit. So they could traffic or travel to the brain. They could localize in the heart. They might, get stuck in the kidneys. There are many different places in theory where the valley fever spores could begin to cause an issue. And in fact, they don't even have to localize into one particular part of the body. They can, stay in circulation. And we talk, and this is perhaps the most common form we see, where we don't point to a particular organ that's affected, but clearly the patient overall is ill and certainly not feeling well. And so when we talk about what owners can look for or recognize, it can be a little bit of a challenge because there's not one consistent presentation that we rely on as an aid to diagnosing the condition. Now, on one hand, if you were to read in a textbook for some of the clinical signs associated with the classic presentation, you would see that dogs, since this is something that typically affects dogs far, far more than cats, they're lethargic. And as a consequence, they have a diminished appetite. They might have a fever. Certainly, one of the characteristic classic signs is a sort of a dry, hacking cough that can develop. You can sometimes see a lameness that occurs if valley fever chooses to affect the bone. Might affect the eye, it might affect vision, or at least the appearance of the eye. So there's a sort of a spectrum of symptoms that can occur. And I think it's probably reasonable to say that since it is something endemic to this part of the country, we as veterinarians tend to recognize that fact and always have it on our sort of list of possible, explanations for whatever's ailing your pet, because it is so clever at times. And this, as we'll talk about in just a few minutes, this also applies to the sort of clever way at times that we need to arrive at a diagnosis, simply because sometimes it's not as straightforward as one would hope or expect. I think if from my experience, if there's one clinical symptom above all that tends to be fairly consistent among most of the patients, it's that they're definitely what we say ADR. They ain't doing right. They're lethargic, and oftentimes they'll come in with a low grade fever. But beyond that, again, it's quite variable. And what's interesting, as we'll talk about later, is that a patient's immune response, how the immune system actually responds, can affect the severity of the clinical signs, as well as our sort of influence our ability to detect and diagnose the condition at times. And we'll sort of, touch on that just a little bit later. But, classically, if we look at the most common disseminated form, lethargy, loss of appetite, perhaps a fever are the things that I would probably rank at the top of the list. Everything else, again, very much depends on, which organ system the valley fever organism localizes in. So, for example, it's not unheard of to see a patient come in who's having seizures or experiencing seizures, and it turns out that that's due to valley fever affecting the brain. And that patient may have none of the other symptoms I mentioned. Similarly, you may have situations where, it migrates to the eye and you have a lot of inflammation, infection, and perhaps even other more severe conditions that affect the eye. Now, with respect to the other mode for getting valley fever, that is what I referred to as direct inoculation, where let's say you step on a stick or you step on a thorn and the valley fever spores make it directly into that location. What happens from that point on, again, very much depends on whether the spores gain access to the general circulation. In this case, you could easily have some of the symptoms I've already mentioned, but in theory, with this type of exposure, it's also possible to have a very localized reaction. So, for example, it looks like you have a wound similar to what you might experience if you, again, stepped on maybe a small thumbtack, but it tends not to go away with treatment. Treatment being perhaps the use of an antibiotic or some anti-inflammatory medication, and it persists. And when we go through the process of diagnosis for something like this and say sample the tissue or take a biopsy, we actually see the organism under the microscope, and that's how we arrive at the diagnosis. But when you have a situation where you have direct inoculation, again, you may not get systemic signs. It may stay quite localized to that part of the body. Now, one of the bigger, I'm not going to say challenges, but I think points of confusion, both for new veterinarians and for a lot of the clients that we see, is how we go about diagnosing valley fever. It would be great if we had a simple, effective test that was very black and white, one that allowed us to basically just get a yes or no answer. Yes, you have the condition. No, you don't. But that only exists in a very small percentage of cases, as I'll describe here in just a moment. When we're looking to establish a diagnosis of valley fever, we really rely on several different pieces of information, kind of like a puzzle, and we put those puzzle pieces together to arrive at the diagnosis. So first and foremost, obviously, we want to see a patient that has a history that would be consistent with a valley fever infection. Again, we had talked earlier about some of those clinical signs that might be present, and obviously, one of the considerations is having a pet who's been here for a little while. For example, a dog that comes to us having only been in Arizona for 1 week with symptoms that might suggest valley fever, and the odds of that dog acquiring and manifesting those symptoms in a week is pretty unlikely. Obviously, if we have a dog here that's been present in Arizona for 4 or 5 years, they've had ample opportunity to be exposed. So having a compatible clinical history is important. With respect to our physical exam, there are not always things that we can see, hear, or feel in the patient that tell us, oh yes, this patient has valley fever. For example, on occasion, we'll see a patient that has enlarged lymph nodes. Well, while valley fever can cause enlarged lymph nodes, I would say that it's probably not the most common cause of seeing enlarged lymph nodes, especially multiple enlarged lymph nodes. So it's not what we call a pathognomonic symptom, a symptom that we can directly attribute to valley fever. I'm sure if we listen to the lungs, if we hear a cough, if we take their temperature and find they have a fever, those are all physical exam findings that we can look towards and say, sure, yeah, this appears consistent with this diagnosis. But now we progress to the more objective tests. Of course, one of the first things that we typically rely on is, what we sort of casually refer to as a test for valley fever. Well, first and foremost, this is a blood. And most commonly, what we do is we measure or we look for two different types of antibodies that are present in the bloodstream. Now, one really important consideration here is to recognize the fact that having antibodies for valley fever by itself does not confirm the diagnosis. Okay, there's certain circumstances where that might be the case, but by and large, when we're looking for antibodies in the blood, it's possible those antibodies are there because there's an active infection, but it's also possible those antibodies might be present from a previous infection that resolved, and they're sort of left over. You can't look at the test results themselves in a vacuum and necessarily arrive at a diagnosis. The two types of antibodies we refer to are what are called IgG, or immunoglobulin G, and IgM. And when we all do the test here in Arizona, we're measuring both. What's key here is to realize that the results are reported differently and we interpret them a little bit different. For example, when IgM is an antibody that's only produced usually very early in the infection and disappears. So when you perform this test and you find that the animal is positive for IgM, that in and of itself is a very strong singular piece of evidence. This pet probably has an active valley fever infection. In fact, in those patients that tend to be more severely infected, oftentimes they can have a persistent IgM value or a positive finding that never goes away, which in those cases suggests that the patient's immune system is not capable on its own of actually handling the infection. But that's the exception rather than the rule. If you ask me, well, how long does IgM remain present in the blood before it disappears? Kind of depends on the patient, but we're looking probably on the order of a few weeks. Whereas the other type of antibody we measure, IgG, can potentially stick around in the body for years. With respect to IgG, when the result is reported to us, we get a numerical value. And again, this is not a black and white test. Yes, it can be reported as negative, but when antibodies are found, without getting too technical, we look at ratios. So for example, the reported result might be 1:2, or 1:4, or 1:8, or perhaps even 1:128. And typically when we see a valley fever titer above the 1:4 threshold, let's say 1:8, with compatible clinical signs, whether IgM is positive or not, we look towards that patient and say, you know what, this patient likely has valley fever. One important point to note is that that number that's reported does not necessarily correlate with the severity of the disease. In fact, oftentimes patients who have a lower number, let's say 1:2 or maybe 1:4, are the sicker patients versus those patients that have the very high numbers like 1:128 or 1:256. And that likely has something to do with the fact that in those patients that have the very high numbers, their immune systems are doing a much better job of mounting a vigorous response. Whereas those patients that have the lower titer and tend to be sicker, their immune systems on their own are not doing a great job of controlling infection. Now, doing this test, and I'll point out, there are currently, at least on the human side, several what we call bench-side tests that can be done in the clinic in about 15, 20 minutes. And in fact, here at North Scottsdale, we do have it, but we rarely use it because there's a lot of technical issues with the test at present. However, it does exist at some of the emergency clinics in the Valley, and they use it on occasion to see if they can establish a diagnosis more rapidly. Relevant only because, it takes about 3 days for the test results to come back to us, and there really is no way of rushing that test result. So you get it back in, say, 24 hours. But in terms of other diagnostic tools that we oftentimes rely on, it's not unheard of for us to take x-rays, for example, of the chest if we have a patient who has a cough. There are some lymph nodes in the chest, for example, that at times can be enlarged And if they are, and you have a patient with compatible clinical signs, again, it's stronger evidence that in fact valley fever may be the diagnosis you're seeking. And in fact, there are cases where valley fever can affect the sort of entirety of the lung fields, and it's a very dramatic thing when you do see it. And if present, obviously, it lends itself to establishing a definitive diagnosis sooner, even while you're waiting for the blood test results. So radiography or certainly one of those useful diagnostic tools, and can be also because valley fever at times does affect bone. And I'll point out, unlike other diseases that we deal with, infectious diseases, for example, valley fever seems to affect bone more than joint. For example, some of the tick-borne diseases that we see in dogs typically affect the joint more than the bone. And so this is at times where x-rays can be really useful, not only to localize, but visualize what's going on with the bone. And seeing that really narrows our focus down to just a couple of things that we'd be concerned about with respect to making the diagnosis. The blood work we sometimes consider is more routine. For example, something like a CBC, which allows us to look at the distribution of red and white cells and platelets. And we can see certain patterns which more commonly occur in patients who are valley fever. So that's a piece of circumstantial evidence that helps to lend itself to the diagnosis. And of course, we want to at times look at basic organ function, not only because we have to perhaps use medication to manage the condition, but also because we want to have a sense of whether any other organ systems might be affected. Now, on that note, I've already mentioned several systems which we see that could be affected by valley fever: the bones, the brain, the heart, the lungs. However, one interesting thing about valley fever is it doesn't seem to affect the GI tract, or at least in only exceptionally rare cases. I even mentioned that it could affect the eye. So that, a patient that comes in with GI signs alone, is not a patient in which we probably look towards valley fever, as a likely culprit. Now, there are other circumstances where establishing the diagnosis may require us to get a piece of tissue, as in the case, if we have a wound on the skin that's not healing, or perhaps in a situation where we have, visually we can see something going on in the lungs, and we're uncertain. So we go in with a camera and a scope and we take a sample of that tissue, send it to the laboratory, and they'll end up not culturing it. In other words, not trying to grow it in a petri dish, but actually looking under the microscope to see if they can actually identify the organism. And sometimes that's what's necessary to confirm the diagnosis. Not every patient who has valley fever is going to play by all of the rules. And I say that only because we do often sort of deal with, not often, but on occasion, we deal with situations where we have a patient in which we strongly suspect valley fever, but we don't have test results that are consistent or compatible with a diagnosis. We have a lot of other circumstantial evidence. And times, when we run the tests and we're not getting the results that we expect, sometimes we'll go so far as to even trial treat these patients and evaluate their response to determine if, in fact, valley fever is present. And we'll sort of touch on this a little bit more when we talk about the valley fever vaccine, because, historically, going back now close to 100 years, there were certain risk factors that were associated with dogs who, in theory, got valley fever. If they lived in certain parts of the valley, if they dug in Indian burial grounds, if they lived next to a construction site, all these things were thought to influence a patient's risk. And in fact, even more recently, digging, a dog that digs, in theory, may expose the body to more spores than a dog that doesn't dig. But ultimately, one of the key factors here, and I'll say that oftentimes I use the example of saying, well, if you have 10 dogs who live in a house, all in the same environment, and 2 of those 10 get valley fever, why those 2? Why not the rest? And this likely has to do with the individual's immune response to the valley fever organism. And that's key. And this sort of relates back to what I was saying with respect to measuring the amount of antibodies in circulation. That is to say, those patients that have a very low antibody titer, that are very sick, may in fact not have as a robust immune response as another pet might. So therefore, in this situation, this household with 10 dogs, those 2 patients that are affected may not have a vigorous immune response, at least enough to get control and battle the infection on its own. So yes, a person sort of, let's call it, you know, individual response or immunologic constitution may have more of an influence than the environment they live in. Because let's face it, there's quite literally probably, 1 million more dogs in the whole Phoenix Metro Valley, and we're not seeing 50% of these dogs come in sick with valley fever. And I should say that when it comes to the risk factors between, say, dogs and people, dogs seemingly are a little bit more susceptible to it. I'll also point out now that valley fever is not contagious. It is not something that if you get and you breathe on your dog is going to get, or vice versa. It does not traffic between dogs and people, dogs and cats, cats and people, anything like that. You do have to really get it from the environment. There are exceedingly rare cases that are in contrast to that. I'll also point out, since we really haven't talked much about this, is that cats, in theory, can get valley fever. We don't see it very often. And I'll say from personal experience, when I have, it usually tends to be something that occurs on the skin rather than affecting them systemically. So, but again, that's exceedingly rare. Is it because I live indoors versus outdoors? I don't even think that factors into the decision. I don't know that a good answer actually exists or has been published to explain why they're at less risk. So getting back to the diagnosis for a moment, it's not always straightforward. There isn't necessarily one prescription or algorithm that has to be followed. But by and large, the majority of patients are going to be diagnosed based on their consistent clinical signs, a blood test which looks at the antibody titers, and possibly some additional blood work or x-rays, perhaps x-rays of the lungs that help to, in this case, say, identify enlarged lymph nodes. And from that, we're able to get comfortable with a diagnosis. Now, years ago, and I'm sure you people can still find posts or stories of those that had to deal with valley fever 20, 30 years ago. But unlike the experience that would have been had, like say in the 80s or 90s, treating valley fever in most patients is quite easy and simple. That is to say that we use an oral medication, most commonly a drug called fluconazole or diflucan, which by and large is well tolerated by the majority of dogs. It comes in a tablet or an encapsulated form. You can also, get it as a liquid or even sort of produced in dog treats if it's easier to administer that way. And not only is it typically well tolerated, but it does tend to play well with a majority of medications that we commonly use even to manage other conditions in veterinary medicine. It is something, unfortunately, that has to be given twice a day throughout the term of treatment. And when it comes to the term of treatment, as we'll discuss, it's not nearly as short as what perhaps you've experienced when treating a bacterial infection. So it's not uncommon to see patients who are on fluconazole for a period of 8 to 10 months, sometimes even longer. Now, during that period, I'll point out that it usually takes a couple of weeks of fluconazole before these patients really start feeling well. But during the rest of the treatment period, oftentimes you have no idea. Somebody walking in off the street will look at your dog and say your dog is perfectly normal. There's nothing wrong with it, as long as they continue with the medication. And I mention this only because at times, people might get 3 or 4 months into the treatment, say, hey, my dog is doing great. They take their pet off fluconazole and they get sick again. One thing to realize here is that with this type of drug and other drugs that are similar to it, we're not actually going after and killing the fungus outright. We're weakening it and then relying on the immune system to do the lion's share of the work in terms of clearing it from the body. Now, there is a drug in particular that can be used that can directly attack the fungus, a drug called amphotericin B. And we only use it on very rare occasions because there are potential complications and other sort of issues with other organs that we can induce when we use this drug. So it's typically reserved for those very resistant or hard to treat cases. Now, just for a moment backing up, we talk about this as a condition that affects dogs more than cats. And it has been reported in the veterinary literature that there seemingly are certain breeds that are a little bit more effective. Now, I say this, and the caveat here is it's not like we have an abundance of studies which confirm this beyond a shadow of a doubt. I'll mention one in particular because, at least from personal experience and what's cited in the literature, there's some consistency, and that is the boxers, or boxer crosses, for whatever reason, seem to be at times more severely affected. But this is a condition any dog, big or small, can get. The question often comes up, well, I have a 6-pound Chihuahua. I live on the 6th story of a building. The dog never touches the ground. Well, you don't live in a hermetically sealed environment, so that dog still potentially is breathing in spores make their way in, through a window or a doorway. There are other breeds that certainly are cited as being more at risk. Again, the literature that really confirms that is thin, so I hesitate to mention too many. But the boxer breed is one that is reported, in several different studies, and certainly from experience, they do seem to be a breed of dog for whatever reason that can be not only that are affected, but can be more severely affected than the average patient, that we see. So with respect to treatment, oftentimes the period, I would say on average, can be anywhere from 8 to 10 months. And during this period, we're monitoring the patients, oftentimes using one of the same tests that we use to diagnose the condition. That is, we're using these antibody titer tests to monitor the level of antibodies in blood. And ideally, what we're looking for is for them to slowly decrease over time and ideally get to the point where they're completely negative. Getting to a negative is not a necessity. That is to say, as I mentioned previously, some of the antibodies may stay in circulation, might be present for years. So waiting for a negative test may cause a particular patient to be on medication much longer than they need to be. Again, 8 to 10 months is an average. Oftentimes when we get really close to being negative, patients doing great, it's not unheard of to give them a trial off medication and then even retest for the antibody level just to make sure that it's not beginning to rise again after removing the patient from the medication. A couple other things certainly to consider. We do have circumstances where we cannot rely on a measurement of antibodies. For example, we had a patient we diagnosed that had very few, if any, antibodies to begin with, and therefore their immune system is not doing a good job of producing them, hence monitoring that level may prove to be somewhat of a challenge. And admittedly, in those patients, just like in patients who are affected in the bone or the brain, those are patients that typically have to be on fluconazole for life. We find that those infections remain active if those patients are not kept on medication. The flip side, of course, is if they are, then they can live, a normal, healthy life. And, somebody walking into your home could never tell that, this particular patient, your dog, has a bone lesion or a brain lesion that's being actively managed, caused by valley fever. Now, fluconazole or fluconazole-like drugs are not the only drugs available, and we do have about a handful of those drugs, some newer ones as well, that in difficult or challenging cases can be brought to bear. At times, believe it or not, we even combine antifungal drugs from different classes together to get a better response in patients that won't respond to fluconazole alone. But the need to use some of these more serious drugs, oftentimes need to be given intravenously, those cases are few and far between. They exist, but fortunately, there aren't many of them. Now, I do want to point out, and this is less the case than it used to be, but there are folks online who advertise certain types of supplements which they claim cure valley fever. And that just isn't the case. We know enough about valley fever, particularly because of all the work that's done on the human side, to understand that those patients that are susceptible because of very specific deficiencies in the way their certain types of white cells called T cells function. And there are no supplements out there that are going to target these specific T cells to do a much better job of recognizing the infection and then triggering the immune system to target the infection so that we can get rid of it. Admittedly, we don't oftentimes use any type of supplements in conjunction with drugs like fluconazole because there simply is no value. That's not to say that we couldn't use medications to at least over short periods make them feel better. So for example, when we have a newly diagnosed patient that doesn't feel great, has a bit of a fever, might have a cough, doesn't want to eat, sometimes we might use a little bit of a steroid for a few days to jumpstart not only their appetite, take away the inflammation, make them feel better and even lower the fever, or perhaps even use something, say, like an appetite stimulant to get them going and feeling better. But over the long term, we rely on medications that are specifically designed to target the fungus itself. One of the good things is that there's not a tremendous amount of monitoring that's necessary of, say, major organ function when patients are on these types of medications, except in rare cases. And for the most part, the medications, as I said, are very well tolerated. There's a relatively small number of patients that experience side effects that would be of concern. So for the remainder of the treatment period, again, which could last 8 to 10 months, these patients seemingly look and act perfectly normal. Now, one question that comes up is, okay, once we've completed the course of treatment, is my dog at risk for getting valley fever again? Well, I think the clearest answer, believe it or not, is yes and no. It is possible that your pet could be re-exposed, reinfected, and develop an infection at some later date. But as I indicated when it came to discussing antibody titer tests, it's also possible that your immune system retains a memory of the infection, and therefore, in retaining that memory, has the ability to do a much better job of fighting it off if you're exposed or at risk again, preventing anything that your pet may have experienced the first time around. So it is possible you could be reinfected, but it doesn't mean you will be reinfected. So just as a side point, that's a question that often comes up. Now, one of the, I would say, more exciting things, but admittedly one of the things that I see those of us in practice have a lot of questions about, is the introduction of a valley fever vaccine, which is supposed to be introduced this year. And one of the things that we're excited about, certainly, is that this strategy for development of this vaccine relies on some new science from the plant world. And at the same time, at least in theory, all this hasn't been demonstrated, this may prove both to be a preventative measure that we can take in patients that are at risk, as well possibly as a treatment option, although again, I'm speculating a little bit there. What's new and novel about this vaccine is that, unlike a lot of the traditional vaccines we use to treat common diseases like rabies, for example, which take just a dead virus and rely not exclusively, but in large part on an antibody response. One of the things we recognize and always struggled with is that fighting off a valley fever infection doesn't just rely on the antibody response, something called humoral immunity. It relies on what's called the cell-mediated response. So the white cells that are part of our immune system are really relied upon to do the lion's share of work at attacking the infection. And it's always been a challenge, at least with respect to fungal infections, to formulate a strategy or a vaccine that's effective at doing just that. Well, in fact, the company has seemingly managed to do that, called Anavive. And it's rather clever because what they've done is they've actually taken a strain of valley fever and they've identified one gene that is key to making the valley fever organism problem. It's what we sort of term as a virulence gene. And what they've been able to do is knock it out. So in essence, this vaccine contains a weak form, but live form of the valley fever organism, which is now able to stimulate the white cells, which make up the cell-mediated immune response, and stimulate the production of antibodies. We refer to that as the humoral response. So we have a more complete immune response to the infection. Granted, we're still waiting for more literature to come out, and one of the key things here is that those of us in practice in endemic areas really need to get our hands on it and start figuring out who's the best candidate. Should it be given to everybody? Or, for example, should it be given to patients who are potentially immunocompromised, immunosuppressed, or have other diseases that would put them at increased risk for valley fever? Should all boxers get it? Those are questions that we can't exactly answer just yet. The other thing I'll point out, and this is always a concern for folks when it comes, at least historically was a concern for folks about vaccines, is that it doesn't have any chemicals to artificially sort of stimulate the immune system. This was an issue a while back, really more in cats than dogs, but it was an issue that at times could lead to tumor formation. And so this type of vaccine doesn't need any of those chemical stimulants. Now, When it's launched, it's going to be incumbent upon us working with the folks who are doing sort of the basic research to determine what candidates really fit the profile as benefiting the most. Because let's be honest, as I said, we may have, let's say, 1 million dogs in Maricopa County, but 500,000 dogs are not likely getting valley fever every year. So while in theory, every pet could be a candidate, I think at least at the outset, we as practitioners are going to make more judicious choices. At the same time, when it comes to treating pets with valley fever, it remains to be seen whether this could be a tool to help jumpstart the immune response. Because remember, as I said earlier, some of the sickest patients are those that have a poor immune response to begin with. And if we can anyway jumpstart that or stimulate that, something that the medications don't do, then perhaps we can enhance the overall response. Now, these are, I suppose somebody could say, somewhat speculative questions, but for us as practitioners, they're exciting questions at the same time because it presents us with a new opportunity, both to perhaps reduce the number of cases that we see and manage those cases hopefully more successfully than we already do. And one other take home there is that even without the vaccine, for the largest majority of patients who get valley fever, that is canine patients, we are able to treat them successfully and do so with a minimum number of side effects. There are exceptions. As I said, patients who are typically affected in the brain or in the bone oftentimes do need to stay on medication for life, but in doing so, live a perfectly normal life. Those are truly exceptions rather than what we see on a daily basis. I do also want to point out, stepping back for a moment, that at times we do see spikes in the number of valley fever cases. For example, when we used to get these big haboob, these dust storms that would stir up so much material into the atmosphere, I would say from experience, it wouldn't be uncommon for sometimes a couple months later to see a spike in the number of newly diagnosed cases because we put so much more material into the atmosphere. Of course, when the rains come at times, that could stimulate, aerosolization of more of the spores. While this was studied very early on, sure, in theory, if you live near a major construction site that was turning over a lot of dust, that's also a possible situation that could lead to, say, a spike in cases, at least locally around that area. So we have, anyway, getting back to the vaccine, we have some exciting things to look forward to. And, certainly valley fever is clever. It's unfortunately something that is here with us to stay. You are not going to get rid of it unless you seal yourself in a special room, which none of us live in. And but nevertheless, I would describe it for most clients at best as a minor inconvenience because of the little bit of cost associated with the medication and the need to give the medication over a prolonged period of time. But unlike our experience, say 30 years ago, it's a very manageable and oftentimes treatable and curable condition. So with that said, I wanted to obviously let Olivia chime in if she had anything she wanted to add, but kind of open the floor for those of you if you guys had any questions or things you wanted to discuss.
I think you did a great job.
You don't want to add anything?
No, I think you did a great job.
Any of you have any specific questions about cases or anything else? Harry, Tanya, Judy, anybody? I know there were some other people on, but looks like they popped out. So
I've got a question. This is Judy. About 10 years ago, we were seeing in the rescue, with the Golden Retriever rescue, I calculated the numbers as vet care person, and we were having like 23% of our case of the dogs coming in had valley fever. Then it got to the point where we were still testing, but we were getting very few positives. Now it seems to be coming up again. And we're seeing more cases. We're still not testing all the dogs as we once were, but we're seeing more cases. Is there any particular reason for that?
I'm not aware of an atmospheric or environmental change that would be responsible for that. Certainly, when you're talking about a particular breed, in my mind, and this is just my opinion talking, I would look more towards, whether there are any common denominators with respect to where these dogs are originating from. and whether there's some sort of genetic link to these patients that might make them a little bit more susceptible. As I was saying before, when you have a group of animals all living in the same environment, but only a minority gets sick, whereas the others are perfectly fine, you have to look more towards the variation that exists in those individuals, in this case, with respect to their immune systems versus the environment they're raised. But I'm not aware, at least, or even climatologically, of any significant or substantive changes that would put these patients more at risk. The other thing to consider is whether any of those patients have any concurrent conditions. So, for example, do they have other underlying diseases that could weaken their immune response, or what their condition was like? I mean, I mentioned that, you could have a particular disease that would weaken your immune system and make you more susceptible. But from a rescue standpoint, how were these dogs that are being rescued raised? Were they fed poorly? Were they not exercised? Were they in very poor condition? And did that poor condition and then stress contribute to weakening their immune system, making them more susceptible? I would look at that as a possible, explanation as well.
At least two of them were in poor situations, so that could be it. I found it interesting because I've had a lot of Goldens, and I've only ever had one with valley fever. It was treated and he was fine, and he was the only one that came from out of state. All the other born and bred ones, I don't know if there's any rhyme or reason to that, but we're taking in more dogs from other parts of the country now, and I just don't know if will they come in with more likely to get it or less likely, or no difference?
So their point of origin really doesn't have much of an influence, because it doesn't really influence necessarily what their immune response would look like. And certainly the geographic distribution of valley fever has increased. You can find it in the Northwest now. You can begin to find it sort of migrating into what they call the Mountain West. Like I said, you can find it in marine mammal species that spend the majority of their days, in the water, but nevertheless get exposed to the spores. But I think it's unlikely their point of origin has as much to do with it as, their genetic composition. How does their immune system behave in response to exposure to valley fever?
Okay, that sounds good.
Tanya, Terry, anything you want to ask about, comment on, criticize? It's all fair game. No? Judy, any other questions?
Oh, gee, I didn't realize I would get extra time.
Well, yeah.
So what I really found the most interesting, I think, out of all this, because I've been living and breathing this rescue for so long and valley fever, is that I had no idea that they could get it from like a stick, that it could be localized.
Sure, in theory, yes.
Yes, and we have had some dogs that have literally come in so debilitated by valley fever that we had to euthanize them eventually, because it would so riddled their bones that we couldn't do anything.
Right. I mean, that is unfortunately possible, and very unfortunate when it occurs, because it is entirely preventable.
Right. Okay, I think that's about it. You've been very thorough. I have lots of notes here.
I do have a quick question. This is Tanya.
Sure.
In your experience, have you seen any patients that tend to be prone to other secondary infections, or say more prone to food allergies or things like that when they are actively infected?
So this is just from experience, and I can't say that I've ever seen anything published to this effect, but no, I'm not aware of any sort of, I guess the term we would use is comorbidity, where a situation where valley fever, occurs in concert with some other particular disease or condition. Even with respect to those more common types of immune-mediated diseases we see, I don't see those as occurring concurrently. When we talk about endocrine diseases, things like diabetes or, thyroid diseases, not usually. I know I can recall, and this goes back a ways, a case report, or at least maybe it was a discussion about whether, hypothyroidism could in theory predispose a patient. But again, it's nothing that's been proven. But yes, based on my own experience of seeing cases in Arizona for, I don't know, close to 22 years. No, I can't think of any comorbid conditions that seem to occur with any frequency or regularity along with valley fever.
Okay, awesome. Thanks.
One more question. Is this vaccine that's come out, is this done in, is this part of some of the work that Lisa Schubitz did down in U of A?
Yeah, so the antibody did work with the folks at the Valley Fever Center for Excellence at the University of Arizona, and she is the lead author on one of the papers, certainly that they published, establishing or determining the efficacy and viability of this vaccine. So yes, Lisa Schubitz was involved. There's been a number of people involved. In fact, at least on the human side, one of the major centers for study is actually at UC Davis in California.
Okay.
But yes, she was actively involved.
I know she spent a lot of years working on this.
Yeah, it's been her.
Yeah.
You know, that's been her lifelong pursuit. I mean, certainly
Yes.
she's
Yes.
yeah.
Great. Thank you.
You're welcome. Well, if nobody has any other questions or comments, thanks to those of you that joined us this evening. We're going to post it on social media and on our YouTube channel. So if anybody wants to look at it again, they're welcome to do so. So thank you, everybody.
Thank you.
Thank you.
Thank you.
You're welcome. Take care.
You
You
too.
too.
Thank you.